morning, everyone. Health and Human Services Committee, come to order, 8:30, Tuesday, March 25th, and we have quorum. We're going to start with Senate File 2706. Senator Wiklund, go ahead.
Thank you, Madam Chair. Senate File 2706 is a DCYF recodification, technical and conforming updates bill. During the 23 and 24 legislative sessions, the Minnesota legislature established the Department of Children, Youth, and Families, and the legislation included establishing the powers, duties, and authorities of DCYF, transferring programs from the Departments of Human Services, Education, and Public Safety, and recodifying statutes and making technical and conforming changes to establish the statutory infrastructure of the new department. This bill was drafted by the Revisor's Office as a follow-up bill to the recodification and statutory updates made during the 23 and 24 sessions for additional updates to sections of statute that were missed in the previous legislation. These statutory updates are technical and conforming changes for programs and services that were legislatively transferred to DCYF during the 2023 and 2024 sessions. The provisions in this bill are necessary to finalize the statutory infrastructure of the new agency and have no fiscal impact. And now I'd like to ask Senate Counsel, Ms. Huffman-Litchie, to give us an overview of the bill.
Go ahead.
Madam Chair, committee members, I will just reiterate what Senator Wiklund said. In 2023, the legislature passed the legislation that created the Department of Children, Youth, and Families, and within that was a revisor instruction that directed the Revisor's Office with Senate Counsel and House Research to recodify statutes within the Departments of Human Services, Public Safety, and Education related to programs that were transferring to the new department and other related statutes. That was worked on throughout the summer, fall, and winter of 2023, and then the recodification bill was passed last session, and those are now in Chapter 142B through H, I believe. And so this bill is just making technical and conforming changes, cleanup, modifying internal references, adding the Commissioner of Children, Youth, and Families into like state advisory boards, or making any other conforming changes needed to assure that the powers and duties from the originating agency are now with the new department. I believe in your packets there's a section-by-section summary that walks through each section with the changes that are being made, and that is the bill.
Members, questions? Seeing none. Senator, any closing comments?
No, Madam Chair. It's just something we need to take care of, and I appreciate the summary.
Very good. Senator Wiklund's motion is to move Senate File 2706 for that file to be re-referred and sent to Judiciary. All those in favor signify by saying aye. Aye. All those opposed? The motion prevails.
Senator Mann, you have Senate File 1407 to start with, and there is an A4 amendment. This bill has already been heard in the Commerce Committee, and so do you want to present your bill and present the amendment, and then we'll take action on that?
Yes, Madam Chair. So 1407 is a technical bill that cleans up ambiguity in the current 62J statute. I spend a lot of my time in the legislature in the healthcare space, both in health insurance and otherwise. And so from the moment that I set foot in the Senate, I've been interacting with this statute, and I have found it to be very ambiguous. Whenever I have bills that deal with healthcare, which is every day, I speak with the staff and I ask, does this bill have to go through this evaluation? And I often get mixed responses because the language in the statute does not reflect the intent of the statute. It does not reflect our practice. We talk a lot about transparency and efficiency in government, and so I wanted to do just that with this process. So this bill will not change our practice. We will still continue doing our 62J evaluations, our reports as intended, as we should, but it will remove the ambiguity that is currently present. It removes vague and therefore unused definitions. It creates a pathway for freshman members to participate in health coverage legislation, which they currently cannot do, and there is no other statute that prevents a sitting legislator from doing their job. And it standardizes the process for everyone. The A4 amendment clarifies language. It's TA from the department and from my Republican colleagues. It changes the head note from rulemaking to adoption of forms, and it deletes section 6. And that's about it, Madam Chair.
Thank you. Members, do you want to ask questions about the amendment first, or can we take action on that? I don't. Or do you want to wait until we have the testifier present? Do you have a preference? Okay. So Senator Mann moves the A4 amendment. Is there discussion on the amendment or questions? Seeing none, all members, Senator Mann moves the A4 amendment. Members all in favor, please signify by saying aye. Aye. Any opposed? The A4 amendment is adopted. And now let us proceed to, we have one testifier, Bentley Graves. Welcome to the committee, and please state your name for the record and begin your testimony.
Thank you, Madam Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. I appreciate the opportunity to testify this morning. So the 62J process is a process that we have been very involved with for a number of years. The reason for that, as you hear in some testimony I'll give in a little bit, is the fact that the majority of our members who offer health insurance do so in the state-regulated, fully insured market. And the decisions made by the legislature with regard to health insurance mandates and taxes and regulations impact directly the benefits that they're able to provide to their employees and also the cost of those benefits. We have been very appreciative of all the work, the bipartisan, bicameral work and support that this process has had over the last several years from the legislature. And the goal here is really just to help make sure that both policymakers, legislators, stakeholders are all kind of reading off the same page when it comes to the cost-benefit analysis and the trade-offs associated with these mandates. We have had a couple conversations with Senator Mann thus far about the changes made here. We would agree that now that we're kind of down the path a few years, there are probably some changes and some updates that need to be made to this process to get to some of the ambiguity and some of the questions that arise on an annual basis. And as Senator Mann said, she interacts with this process probably more than most in the legislature. So certainly has some good experience to bring to this conversation. We appreciate the changes that were made this morning. We still have some questions and concerns about a few of the other changes that are left here, but want to make ourselves continually available to Senator Mann and to others that are working on this process to make sure that at the end of this, we have a process that continues to serve the purpose of providing transparency and accountability to, again, policymakers, legislators, stakeholders, and making sure that everybody has the same information about the trade-offs associated with these decisions. So, again, want to make myself available to continue to work on this. Appreciate the discussions we've had thus far, and thank you, Madam Chair, for the opportunity to testify.
Thank you. Members, do you have questions or comments about the bill? Senator Rodkey.
Thank you, Madam Chair. And I just need a little clarification because I did hear that this bill doesn't change anything in 62J, but I do see that it talks about the language, the fact that it doesn't require the bill language to go forward. I mean, usually the language in a bill is pretty important to the intent. Why would that not be needed?
Senator Mann?
Thank you, Madam Chair. So it's not needed right now. It's just, again, clarification of our current practice. Right now, if you submit language, that language changes so many times that the original language doesn't really matter half the time. So we just cleaned up what is our current practice.
Senator Radke?
Thank you, Madam Chair. The next part that seems to be of a change in the bill language is the fact that medical assistance is not, a fee-for-service part is not part of this. It would have to be named to be part of it, so we're excluding it from the beginning. And I guess just a personal thought there is everything should be included so that at least it's all on the table for discussion. We end up with a lot of these mandates that we spend a lot of time and people put a lot of effort into, and there's a lot of discussion, whether they're good, bad, or indifferent. Most of them are probably for the right purpose, but it continues to drive up our cost of health insurance because somebody's got to pay the bill. And in this case, a lot of the work we're doing is affecting such a small percentage of our population, you know, under 15%. And now we're taking out basically the public pay version, and again, just targeting the individual market. And I guess what is the line of thought behind that? Why not have it included so at least as the conversation goes on, it's acknowledged that everybody starts out in the program. You know, we see it a lot of times, they get pulled because there's a fiscal note. I think that should be part of our discussion.
Senator Mann?
Madam Chair, so 62J has to do with the private plans. It's never had to do with MA. That is a policy choice that legislators make when they go into the process. However, that language was removed with the amendment.
Senator Radke?
Okay, and yeah, that was the, okay, under section 6.
Was removed. But
And the last thing is, we referred to rulemaking, but then we just changed it to adaptation, additional forms, I think is, okay, adoption of forms. Are they one and the same, or are we trying to end run something there? How did that terminology come about?
Senator Mann?
Madam Chair, so we got technical assistance back from the department that they don't need rulemaking to do that. So this was easier just to change the header from rulemaking to adoption of forms to make it, again, a standardized process for everyone.
Thank you,
Senator
Madam Chair.
Other questions, members, comments? I don't see any other questions. I think Senator Mann, I think this is a good idea to work on this, because it has always been kind of puzzling to me that the legislators who haven't even started yet are kind of, you know, something gets in the way of their being able to do legislation when they begin as a legislator. And so I think it's good that we get this cleaned up. If I don't see any other questions or comments, Senator Mann, do you have any final thoughts? This bill will be referred back to Commerce. And so, Senator Mann, your motion is that Senate File 1407 as amended be recommended to pass and be referred to the Committee on Commerce. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 1407 as amended is passed and referred to the Committee on Commerce. Senator Mann.
Thank you, Madam Chair. Senate File 1054 will require coverage of vasectomies. Vasectomies are already covered by public plans. This is a minor surgical procedure that is 99.9% effective. When I think about insurance mandates, I think about three things. Will it reduce morbidity and mortality? Will it reduce healthcare costs down the line? And does it provide a societal good? In this case, covering vasectomies does all three. When men are able to get a 20-minute office procedure, then their partners don't have to get the alternative, which is an intra-abdominal surgery, which comes at increased risk. This happens in an operating room with a surgeon and an anesthesiologist, which is significantly more expensive. And of course, preventing unwanted pregnancies is good for everyone. So it fits all three of my criteria, Madam Chair, and it's quite cheap. And with that, I believe there are some testifiers.
I have one testifier, Bentley Graves. Welcome back, Mr. Graves, and please give your name and begin your testimony.
Thank you, Madam Chair and members. Again, my name is Bentley Graves with the Minnesota Chamber of Commerce. Health insurance is an increasingly and incredibly important benefit in this competitive labor market. It allows employers to attract and retain talent and helps ensure their employees stay healthy and productive at work. About 70% of our members provide health insurance to their employees. 3/4 of them do so through the state-regulated, fully insured market. This allows these mostly small, mid-sized businesses to provide coverage to their employees without having to take on the financial risk of a self-insured, self-funded plan. But it also comes with the second longest list of mandates in the country. Each of these benefits is in place to help people. There's no question about that. But each also comes with a cost. Because of this, we've long encouraged the legislature to show restraint when proposals are brought forward to add new mandates to state statute, but admittedly, this is a tough ask. Fortunately, as was just discussed, the 62J mandate review process requires the Department of Commerce to perform a cost-benefit analysis for new mandate proposals. This process has helped all of us better understand the trade-offs that come with new mandates, but in doing so, these evaluations have repeatedly confirmed the fact that there is a cost associated with mandates, and that's again the case with the 2 coverage mandates under consideration today. And that's a concern because healthcare affordability for employers and their employees is not getting easier. Roughly 3/4 of our members who currently offer health insurance tell us they'll be forced to make significant changes to their offerings, including reductions in coverage and dropping coverage altogether, if costs continue to increase at their current rate. Some have already had to make those hard decisions. 1 in 5 chamber members who don't currently offer health insurance tell us it's because prohibitive cost increases forced them to drop the coverage that they had. There are many components of the cost of health care that are outside the direct control of the legislature, but only the legislature can add new mandates to the health insurance sold in the state. So, on occasions like this, if policymakers decide that there is a public health imperative for additional benefits, we encourage the legislature to marry up its consideration of new mandates like these with Senate File 565. This type of approach offers the state the opportunity to invest in the health of those seeking new mandates while also ensuring costs for those who rely on coverage in the state's fully insured market don't increase as a result. Thank you, Madam Chair, for the opportunity to testify this morning. Thank you for the opportunity to provide this feedback, and I'm happy to answer any questions.
Thank you. I have a testifier, Sarah Gengelhoff. Welcome to the committee, and please state your name for the record and begin your testimony.
Sure. Thank you, Chair Wiklund and members of the committee. My name is Sarah Gengelhoff, and I'm the Director of Advocacy and Innovation at the Women's Foundation of Minnesota. Thank you for the opportunity to support Senate File 1054. Requiring vasectomies to be covered at no cost is now just about expanding access to a medical procedure. It's about closing a glaring gap in our healthcare system. Vasectomies are a procedure that often gets overlooked in health discussions, despite being safe, permanent, effective, and minimally invasive procedure. The imbalance of this discussion sends an outdated message that contraception is solely a woman's responsibility. And this antiquated idea has led to women often bearing the physical, emotional, and financial burden of contraception, from pills and IUDs to surgery. However, women in our state also face access barriers for even those options. In our Status of Women and Girls report, we found that in 2022, about 12% of Minnesota women, 283,000, resided in a contraceptive desert, where they lack sufficient access to health care centers offering a comprehensive range of contraceptive products. Fully covering vasectomies helps redistribute this responsibility, providing balance in health care, empowering men to make responsible choices, and supporting women who may face side effects, health risks, or access barriers to hormonal birth control and tubal ligations. From a fiscal standpoint, vasectomies are a cost-effective solution. A one-time outpatient procedure is significantly less expensive than long-term contraceptive methods. Studies consistently show that investing in health solutions like these leads to long-term savings for healthcare systems. By passing this bill, we would join other states who believe in equitable healthcare. It's a matter of fairness, fiscal responsibility, public health, and personal freedom, and we urge you to support this bill. Thank you very much.
Thank you for your testimony. Members, do you have questions or comments about the bill? Senator Abler?
I was waiting to see if Paul's gonna. Some of this stuff you just put in a quarter and it's the same conversation. And I appreciate the concern about costs, and I really do. It's amazing to me. So Senator Mann, does insurance cover tubal ligations?
Senator Mann?
Madam Chair, I don't know.
Yeah.
Depends on which insurance, I suppose.
No, it just says it covers. I thought you'd just say yes. Anyways, I shouldn't ask questions I don't know the answer to. But it seems to me if they do, this would be, like you suggested, an alternative. I just was kind of curious in that we just fussed about so many things like mammograms. We talked about that some time ago, and that was, the world was going to end if we did that, and I guess it hasn't. Maybe that's why insurance costs are so high, because of all those mammograms. Anyway, but just on line 1.12, whenever this got passed, somehow the compromise was to exclude vasectomies. So I don't remember that conversation, but that must have been an interesting one. And anyway, so I think it's a good bill. And just over time, I wonder though why the plans have to be told to do everything. And there's seldom a voluntary benefit that they go to that seems like it would be worthwhile. And if indeed this would save money, I don't know why the big fuss. And they kind of lack creativity, it seems to me sometimes. And I mentioned in my last more longer conversation with you at the table that actually we invented them. And we want them to succeed. We need them around. I don't think there's a huge gap if they go away, and some people hope that they would, but I don't see that happening. But I do think they need to remember their responsibilities to us. So thank you, and to the people they serve. Thank you, Madam Chair.
Senator Port?
Thank you, Madam Chair. Thank you for bringing this, Senator Mann. I've worked on this issue with you, and the cost, the various levels of different healthcare or contraception coverage, and how invasive they can be. You think taking a pill, that's not invasive, but it changes your hormones. It can have radical effects on people's health. And so the more options that we have coverage for means that people can find the option that actually works for their health, for them and for their families. So I really appreciate you bringing this bill. I think it's a great step forward, and I hope we're able to move it forward.
Any other member questions or comments? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Mann, I have, I guess, maybe two questions. One question being, are there any plans currently that do not cover vasectomies?
Senator Mann.
Madam Chair, yes.
Okay.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Mann, I couldn't find any plans that didn't, and so that's why I was trying to figure out what this bill was trying to solve, other than I believe, based on reading through the bill, that it's going to basically eliminate cost sharing, which has a significantly different impact than the coverage issue that we're worrying about. So I guess if there are plans that aren't covering it, then that would be the purpose of this bill. But if there weren't plans, then I still don't understand why we would eliminate cost sharing when cost sharing at the end of the day is part of the insurance world. And so that's why I'm trying to figure out what the purpose of the bill is if vasectomies are covered by all the plans, which, like I said, I couldn't find any that didn't. So.
Senator Mann.
Madam Chair, so the reason why this bill exists is because I had a patient in the ER who had an infection after her intra-abdominal tubal ligation. She had to take off work, big intra-abdominal surgery. And at one point she turned to me and she said, I'm so angry because I just wish my husband could have had a vasectomy. And I asked her, why didn't he? And she said, because it wasn't covered by his insurance. And I was like, I had that moment where I was like, your intra-abdominal surgery was covered, but his vasectomy was not, and she said yes. So I looked into it, and sure enough, not all plans cover vasectomies. And so that's why we wrote the bill. And cost sharing is a barrier to care, so we added that in there as well.
Senator Liskey.
Thank you, Madam Chair. Thank you, Senator Mann, for bringing that up. That's something that I do find interesting because you're right. Why would one be covered and not the other? It doesn't make a lot of sense. So, I appreciate what you're trying to do here. So, thank you.
Any other questions or comments? Senator Radke.
Thank you, Madam Chair. And this is a little bit of a tongue-in-cheek question, so I just have to ask, because we heard that we are number 2 in the number of mandates that are out there. And after the last 2 years, we've passed, I believe, 14 mandates that have been added to that list. But who's ahead of us?
Senator Mann.
No idea, Madam Chair.
Yeah. Senator Radke.
That's all. I think I can find the answer to that later, but I just had to see if anybody knew. Thank you.
Any other comments, questions? Seeing none, Senator Mann, I do think this is a good bill, and I think contraception should be comprehensive, and it should be available, similar access for men and women, and so I appreciate your bringing this forward. And it does seem like a cost savings and life impact savings for people. So this bill, Senate File 1054, is laid over for possible inclusion. Senator Mann, Senate File 1085.
Thank you, Madam Chair. 1085 is a really important bill that puts all hands on deck when dealing with the maternal morbidity and mortality crisis we have in this country and in this state. Maternal mental health disorders are a leading cause of death among pregnant and postpartum women, with suicide as one of the primary drivers. I know we've heard this before, but the U.S. has the highest maternal mortality rate among other developed nations, with the economic burden of untreated maternal mental health disorders reaching $14 billion. If we treat mental health disorders before they escalate, we can prevent catastrophic outcomes and cut healthcare costs. So what Senate File 1085 does is to ask the plans to establish a maternal mental health framework that are sustainable and come from the top down so that everyone participates. These services are already covered, so we are not asking them to cover new treatment. Other states have done this with success. This will decrease morbidity, it will decrease mortality, it will decrease healthcare costs down the line, and it will absolutely contribute to societal good. I do have a technical amendment, Madam Chair, that clarifies that the plans will ensure an appropriate network of providers. It was just the language change to make it more clear.
So members, this is another bill that came, that has already been heard in Commerce. Senator Mann wishes to move the A3 amendment. Do you have questions about the amendment? Senator Radke.
Thank you, Madam Chair, and I do have a question because we're taking it from requiring at least one maternal mental health screening to now just ensuring the network of providers for this possible screening. To me, it's removing the requirement, and the question would be, is that true, and who's asking for this, or who's bringing this forward that would change it from a requirement to just looking at the network?
Senator Mann.
Madam Chair, so the intent is the exact same. So we want to make sure that everyone has the screenings and has the proper referrals. The language was confusing because some people interpret it as the doctor has to do the screening versus the plan has to require that network be available for the screenings to happen. So we wanted just to clear that up, but the intent is the exact same.
Senator Radke.
Yeah, thank you, Madam Chair. I think I still have a concern with that, but so be it. Thank you.
Senator Abler.
Well, thanks, and we could spend a half hour talking about network adequacy, and what's happened in the fee-for-service Medicaid program, which I don't think this bill is about. Any provider can be in it. In the PMAP programs, they're very limited depending upon what plan and how they're managing things. We use the word desert, and in greater Minnesota there are vast tracts of places that you don't get service at. I complained to the Department of Health about Blue Cross in Sanford that had a deal where in Warroad you'd have to drive to Thief River Falls to get primary care, and driving past many clinics even in your own city, and they totally dropped the ball on that. So I think if you really, I don't know the exact extent of the federal law about mandating mental health parity, but if you have any kind of parity, you better have places people can go. And so I think this, if nothing else, I'm not arguing with my good colleague Senator Uckey about this, but I think it just puts an exclamation point, is that this is something we need to do. And somebody commented, well, I'll go back to I'll just ask my question about this, and if it comes up or not. Somebody said that the insurance already covers this. And I'm not sure how long we want to have the conversation go, but it'd be interesting to see what they do indeed cover. And I have a feeling if people are feeling like that was inadequate, then we need to have adequate care for this perinatal and prenatal and all that time. How many suicides do you want to prevent to make it worthwhile? And how many bad outcomes do you want to have that you prevent to make this worthwhile? So just to the amendment and also to the bill, I think it's really important. And I'm just back to my point of plan responsibility. They design the benefits. They tell you if you get them or not. They set up their programs of deductibles and copays. They decide if you're a specialist or a primary care. And so in many cases, these are specialists, and the copay is twice. And so it's just a dance, Senator Mann, and you're well aware of it. And I appreciate you taking this up today. Thank you.
Any other questions about the amendment? Senator Liskey.
Thank you, Madam Chair. Thank you, Senator Mann. The amendment actually, for me, clarifies things a little bit more. When I'm talking to patients on a regular basis, they talk to me about the network that they're in, and they talk to me about their hunting down where they can go, where they can't go. And the number one thing that I get a lot of in response is, my plan is more affordable, it's cheaper. And then they ask me, well, do you accept this insurance? And I unfortunately, when I see the plan that they have they're excited about because they've had to pay less for, it ends up being a network that I can't even find a provider for in the near area that we're at. And so this specifically gets at this specific issue, but I think we do have a greater issue, is that some plans are offering these great coverages, but there's no providers in the network to provide the coverage. And so that's something that I have an issue with. And so hopefully by seeing how this works, we'll be able to maybe address the issues on the other parts of the networks that are an issue. And so I look forward to seeing how this bill works. So thank you.
Any other questions about the amendment or comments? Then Senator Mann moves the A3 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A3 amendment is adopted. Now we have a testifier on Zoom. We'll have her testify. Dr. Sogan Gassimi.
Morning.
Good morning. Please state your name and begin your testimony.
My name is Dr. Sogan Gassimi. Good morning, Chair and members of the HHS Committee. I'm a board-certified child, adolescent, and adult psychiatrist and the director of our perinatal mental health program here at Prairie Care. I do want to, again, underscore that the U.S. has the highest maternal mortality rate amongst all industrialized nations, and mental health conditions are the leading cause of maternal death, with suicide as a primary driver. 1 in 5 women will experience perinatal mood and anxiety disorders, yet only 25% of them will actually receive treatment. Untreated maternal mental health conditions actually increase the risk of pregnancy complications, preterm birth, and impaired infant bonding. As a child psychiatrist, I see the impact it has in children. It can impair cognitive development, emotional regulation, and increased behavioral issues. Untreated maternal mental health disorders cost Minnesota $326 million approximately each year due to higher medical costs, lost productivity, and increased social services. Despite these risks, the screening and treatment remain inconsistent. Minnesota has a rate under 10% in 2022 of screening. Even when screenings do occur, providers often don't know where to refer patients or what resources exist. Minnesota currently has 705 trained maternal mental health providers who have the certification through PSI, and another 100 providers are being trained in this upcoming April training session. The problem is the lack of infrastructure. Minnesota has the opportunity to lead the nation in fixing this. The bill creates the maternal mental health programs within health plans, ensuring that 1, standardized screenings and referrals so that mothers are identified and connected to the care they deserve. 2, alignment with HEDIS quality measures, improving accountability and outcomes. 3, training for providers, equipping them to screen, diagnose, and refer effectively. And finally, centralized referral network, eliminating delays, confusion, so no mother is left behind navigating the system alone. This bill is supported by a broad network of providers, advocates, and frontline health care workers. This includes Minnesota ACOG, Minnesota Medical Association, and Minnesota Psychiatric Society. At the Commerce hearing, patients and families shared their powerful stories of pain, heartbreak, survival, and resilience. Though they are not here with us today, their voices remain present, and every mother still waiting for care, and every loved one fighting to get them the help they need. We are at a crossroads. We can continue with a fragmented system, or we can build a model that makes Minnesota a leader in maternal mental health care. Our mothers and our families deserve better. I urge you to support SF 1085. Thank you for the opportunity to speak today.
Thank you very much. Members, do you have questions or comments about the bill? No? Okay. Senator Mann, any additional comments?
Well, Madam Chair, just, we're trying to standardize screenings referral. We're trying to prevent delays in care by ensuring immediate intervention, all to tackle this issue. So hope you guys will consider it.
Thank you. Yeah, it seems like, some of the components are available, but they're not, it's not helpful if there's not coordination or a way to ensure that people know about and are trained on these items. And it seems like the plans, it would be helpful for them and a cost-saving measure over time if there was more coordination. So Senate File 1085 as amended is laid over for possible inclusion. And Senator Mann, you have Senate File 1806.
Thank you, Madam Chair. So 1806 exists because I was tired of getting phone calls that went like this. Dr. Mann, I'm at the pharmacy and I'm being told that I can't get my medications. I told them I've been on these medications for 6 years and they said that my formulary changed and I can't have my medications anymore. What do I do? It also exists because I'm tired of having ER shifts where a patient comes in and says, I'm here in the emergency room because I couldn't get my medications on Friday. The pharmacist told me that my meds were no longer available to me and I couldn't see my doctor over the weekend. So now my blood pressure is 200 over 115 and I don't know what to do. These are very real patient encounters that happen irregularly. So what Senate File 1806 does is that it says that you can change your formulary whenever you want, as often as you want, but if a patient is on a medication, they can stay on that one medication that they're taking until the end of the year. Then they can switch. It is not a formulary freeze, it is a patient protection issue. We cannot pull the rug out from under patients anymore and expect good healthcare outcomes. We can't increase the healthcare costs across the spectrum of care in order to save the plans money because they get a nicer rebate from the PBMs. With that, Madam Chair, I do have an amendment, the A5.
Senator Mann offers the A5 amendment. Can you walk us through the amendment, please?
Yes, it does a few things, Madam Chair. It expands the exceptions for instances when a health plan adds a therapeutically equivalent drug to the formulary. So right now in the bill, it says that it has to be a lower cost, but we added in the same as or a lower cost. So again, they can change the formulary. It imposes a requirement that to let patients know when there is a formulary change. And it imposes an annual reporting requirement regarding formulary changes. So we want to know what is happening. This is such an opaque process. We would like to know why the formulary was changed, what drugs were removed in and out of the formulary, how many people were impacted by these changes, so we can really know what impact these changes are having on patient care.
Members, questions or comments about the A5 amendment? No? I was glad to see the reporting concept. I think that's really a good idea. We have sort of an abstract idea of what is happening, but we don't have a lot of tangible information about how often does this happen. So I appreciate that. Seeing no questions or comments about the amendment, members, all those in favor of the A5 amendment, please signify by saying aye. Aye. Any opposed? The A5 is adopted. Now, Senator Mann, we can go to your testifiers. Is that, we have, first I have Katie Smentek. Hopefully I'm saying that correctly. And then Sarah Nispel? Sorry if I'm Nispel. Thank you. And welcome to the committee, and please state your name for the record and begin your testimony.
Thank you, Madam Chair and members. My name is Dr. Katie Smentek. I'm a pediatrician from Mankato and serve as the president of the Minnesota chapter of the American Academy of Pediatrics. I'm here to testify in support of Senate File 1806 on behalf of our chapter and the Minnesota Medical Association. For many of my patients, finding a medication that works effectively can be difficult, time-consuming, and may take extensive consultation with their care team. This is especially true for patients with more chronic conditions. Once a patient and physician find an effective treatment plan, patients will often choose their health insurance based on whether the health plan covers that needed medication. Yet nothing in law stops insurers or PBMs from changing their drug formulary at any point in the insurance contract year. This leads to delays in care, unexpected and increased medical expenses, and overall worse health outcomes for patients. As one example, one of my partners had a child end up in the pediatric intensive care unit with respiratory failure due to asthma because their insurance stopped covering the medication that had until then controlled their asthma symptoms well. While they were working to find a reasonable, effective alternative, the patient's symptoms quickly became out of control and they ended up in the ER. Senate File 1806 would limit PBMs and health insurance companies from forcing a patient to change medications in the middle of the contract year only for patients who have started a treatment plan. Since that patient cannot change insurers until the end of the contract year, insurers shouldn't be allowed to change the coverage for the needed medication until the end of that contract year. If the insurer arbitrarily stops covering the needed medication, many patients with chronic conditions can't simply switch to another medication. It can take time for a patient and care team to find a medication that works well for them, and once a treatment plan is developed, it's important for that patient to stick to that plan. To force a patient to change medications because of a formulary change can put that patient in a very dangerous situation. Thanks for the opportunity to testify. I'd be happy to answer any questions for you.
Thank you. And Ms. Nispel, please state your name for the record and begin your testimony.
I'm Sarah Nispel. On behalf of NAMI Minnesota, I am testifying in support of SF 1806. It's hard to count the number of times we've testified to the negative impact of a plan making changes to the drug formulary, benefits, provider network, et cetera, in the middle of the plan year. It is extremely disruptive to people's treatment. People with mental illnesses often find it takes several trials of different medications to find the one that works. And once we find what works, we don't want to make changes. We fear that if we must change medications, and not on the recommendation of our prescriber, the symptoms, such as devastating depression, being overcome with anxiety, experiencing mania, or hearing voices, will return. we're not talking about an inconvenience. We're talking about symptoms that can completely disrupt your life, your job, your education, your relationships. Thus, many people with mental illness who are choosing a health plan look to see if their provider is in network and if their medication is in formulary and what their copayment would be, and they choose a health plan based on these factors. So to have a health plan change the formulary or the costs during the plan year is a bait and switch. People have chosen that plan because they can access the medications they need and the providers they like. People pay to have a plan that meets their needs. Making changes in the middle of a plan year simply isn't right and causes great problems. It means plan members have to go back to their prescriber to find a different medication, and it can take months to secure an appointment, or pay more for the new medication, which isn't always possible for many Minnesotans. And then, even if by a stroke of luck, after getting your prescriber appointment, after switching meds, the new medication works just as well, you first have to taper off the old medication and then taper up onto a new one, opening the door for severe withdrawal symptoms, new side effects, mood and appetite swings, sleep disruption, and more. So there really is no reason for a health plan to change the formulary mid-year. Hold them accountable for the plan that they offered. I urge you to support this bill. Thanks.
Thank you very much for your testimony. Next, I have Joe Selwood and Michelle Mack. Welcome to the committee, and please state your name for the record and begin your testimony.
Thank you, Madam Chair and members of the committee. My name is Joe Selwood, and I'm testifying on behalf of the Association for Accessible Medicines, the leading trade association for the manufacturers of the generic and biosimilar prescription drugs that saved Minnesota and its patients $6.2 billion in 2023 alone. Senate File 1806 allows formulary changes when replacing a brand name drug with a biologic drug rated as interchangeable. This language does not include lower cost biosimilars. AAM would request that biosimilars be added to the exceptions for the following reasons. First, biologics now account for approximately 45% of drug spending. This disproportionate amount underscores the urgent need for more affordable alternatives through biosimilar competition. Using MDH data, spending on generics and biosimilars accounts for just over 1% of the total annual healthcare spend. Second, the FDA has consistently affirmed that approved biosimilars meet the same rigorous standards as their reference biologics. The FDA recently issued draft guidance on interchangeability, stating that healthcare professionals and patients can be confident in the safety and effectiveness of a biosimilar product, whether or not it has also been approved as an interchangeable biosimilar, just as they would for the reference biologic product. Despite the FDA's reassurances, Senate File 1806 only allows interchangeable biosimilars, which represent just 1.36% of all FDA-approved biologics. Lastly, over the next decade, 90% of biologics will lose patent protection, creating unprecedented opportunities for biosimilar competition to drive prices downward. By adding biosimilars, Minnesota can position itself to fully benefit from these savings by ensuring our laws don't inadvertently create barriers to biosimilar adoption. Thank you for the opportunity to speak, and I'm happy to answer any questions.
Thank you for your testimony. Ms. Mack, please state your name for the record and begin.
Good morning, Chair Wiklund and members of the committee. My name is Michelle Mack, and I'm the Senior Director of State Affairs with the Pharmaceutical Care Management Association, otherwise known as PCMA. Thank you for the opportunity to provide testimony to Senate File 1806. PCMA is the National Trade Association representing America's pharmacy benefit managers, or PBMs, which administer prescription drug plans for more than 289 million Americans with health coverage provided through employers, health insurance plans, labor unions, Medicaid, Medicare, federal employee health benefit programs, and other programs.
We appreciate the sponsor's numerous exceptions made to the bill, which we have discussed in various iterations for the past few years. However, at this time, PCMA is opposed to Senate File 1806. While there is an exception allowed if there is a change in the drug safety, there is not an exception for a drug shortage situation. We need to be able to change formularies when a drug is limited or on back order. In addition, the language does allow for a generic or biosimilar drug to be substituted for a brand product. However, it does not allow changes that result in a lower net cost to the plan sponsor. PBMs need to be able to make changes during the plan year to the formulary when pharmaceutical manufacturers increase their prices. As an alternative, we suggest an amendment that would require pharmaceutical manufacturers to freeze their prices for the calendar year. It is for these reasons we are opposed to Senate File 1806. Thank you for your time and consideration. I'll stand for any questions.
Thank you very much. That concludes our testifiers. Members, do you have questions or comments about the bill? Senator Abler.
Well, I appreciate Ms. Mack coming up, and I guess I'm not surprised that they're opposed. Is anybody from the health plans planning to testify why they think this is a good idea to change the formulary in mid-year or not, Madam Chair? Can I ask them to come up, or would that be inappropriate?
Senator Abler, I mean, I think if there's someone here you want to ask a question, I guess I can't preclude you from doing that. There isn't anyone else signed up to testify.
Right. I don't know, is this a conversation or is this just, I don't know, do you want to come up? And the question I'm going to ask is, how do you justify it? And clearly you do it as plans. In mid-year, people sign a contract. And I think somebody should come and defend why that's a good idea. Ms. Mack had her point of view. It's, you know, kind of about the money, it seems like, to summarize. And I don't know, this to me seems like a real ethical dilemma. When you have a contract and you break the contract. I'm a provider, I have a contract. Actually, they can break my contract whenever they want, some of them. They can just kick me out for no reason, even though I have a contract with them. And so, Senator Mann, is this bill going to pass? Are we going to argue about this again for a year and then nothing's going to happen so that people will have their contracts broken in mid-year still?
First, I don't know, Mr. Andreessen, did you wish to comment or not? You don't have, okay. Senator Mann, do you want to respond?
Madam Chair, I'm here with the hopes that it will pass.
Anyway.
Senator Abler.
I don't know why we keep talking about this, Madam Chair. I just, you know, I woke up in a good mood today and everything, but this is the committee that these discussions are happening, and the House is perhaps having those same conversations, and I don't know. I'll stop, but I just wish that when people oppose a bill, they come up and oppose it to our face and not work to kill it behind the scenes. And I appreciate Ms. Mack coming up and expressing her points of view, and I don't agree with all of her points of view on things, but anyway, so thank you, Madam Chair. Can this go to the consent calendar? Thank you.
Senator Port, I saw.
Thank you, Madam Chair. You know, Senator Mann, when we hear that we can't do this because it's too costly or, you know, it's too much uncertainty or what if this or what if that, all of those questions are patients. They are patients who have, like Senator Abler said, who have a contract, who need coverage for medication. And I really appreciate the testifier from NAMI who talked about how hard it is to switch medications on a dime and how that can work, but it doesn't always work, and how it takes time. Those things can impact people's health in really big ways. Maybe it saves a little bit of money, but what is the cost to people? I love this day for you, and hopefully for us and for patients, because these are all patient-centered bills. How are we actually serving patients? I think this is a great bill. We should pass it. And, you know, Senator Abler said this is an ethical dilemma. It doesn't feel like much of a dilemma to me. It feels like a pretty obvious bill that we can pass that will help keep people on the medication that they need to be on until they can make the change in the next year or find a different plan that covers what they need. So really appreciate you bringing this bill, appreciate all of these bills today. We should not wait any longer. We should pass this.
Senator Bolden.
Thank you, Madam Chair, and thank you, Senator Mann, for bringing this bill. This is something we should do. This is something we should have already done. This bill has been, you know, it comes back year after year, so thank you for your persistence to bring it back yet again so we can talk about it. I hope we can move it forward. And I appreciate Senator Port's emphasis on this is about patients. This is a patient safety issue. You know, I experienced this in my practice as well. I worked neuro for a long time, and I think specifically about a patient I took care of who was hospitalized with seizures because he, you know, had a regimen that worked for him, was on medications, a couple of them that worked for him. Change in the formulary, couldn't get the medication that worked that his doctor had prescribed. They had worked for a long time to get him on a good regimen and have his seizures well controlled, and then had to change medications and it wasn't working. And he ended up hospitalized with seizures. And so it's just like one example, but it's in every space, right? We talked about mental health issues. You talked about others. And so this has real impacts on patients. And this is yet another way that health plans stand in the way and are a barrier for the care that a provider says is needed for a patient that they then just can't get. And so it is a contract that is being broken. And more importantly, it is patients who are not getting the care that they need and deserve and has been prescribed by an expert care provider that says that they need. And so I am frustrated that we are, you know, back again and have not done this already. I hope we can move this forward this year. So thank you.
Thank you. Senator Utke.
Thank you, Madam Chair. And just for clarity on who is actually covered by this bill, just looking at the bill summary that we all get, and it talks about the prohibition applies to health plans in the private market as well as the state's medical assistance program. Where does CGIP and MinnesotaCare fall in? Are they not part of this? Or I guess I'm wondering who's included and who's not.
Senator Mann.
Madam Chair, they're all included.
Senator Radke? Okay. Any other questions? Senator Liskey.
Thank you, Madam Chair. Senator Mann, I'm happy to be a co-author on this bill. I find it interesting that there was some notes that say that it's rare, that this doesn't happen very often, and yet I must be part of that rare occurrence because I was at a pharmacy and had a prescription sent over, and according to the provider and to my insurance when I looked it up online, because as a provider myself I can look up what my coverages are in a different way than most patients can, it said that it was covered, and by the time I got to the pharmacy, the pharmacist told me, unfortunately, last month, this was taken off of your formulary. And I went, wait, what? And so I had to now scramble and call the provider and get a new prescription sent over and wait for another 2.5 hours at the pharmacy while we straightened out the issues of the fact that the medication I was trying to get wasn't all of a sudden available. So I find it interesting that we're told that this is going to have a cost when I would think that the 4 hours or whatever it took to get the prescription figured out also has a cost. It's frustrating to me that this is a constant argument that we have, that this is a bad idea. Things aren't working. Things are broken. We got to fix them. And so when we see this happening, something needs to be done and it needs to be addressed. So I appreciate it. Thank you.
Any other member comments or questions? I don't see any others. This is a bill that, you know, I think I've signed on to it multiple years, and over time, really, I've been frustrated that we haven't been able to move it forward and get it passed. Over my years in the Senate, it's just been frustrating and heartbreaking to hear from people, constituents who are on a medication and get established on it and benefit from it, and then have a sudden change happen, and they're told they can't get it anymore, and just the time and effort and, cost to their health is really troubling. And this whole inability for patients to have the power to opt out of a contract in the middle of the year, it just doesn't make sense that we can't have this expectation that you choose something, you choose a plan, you are able to get your medication, that you should be able to continue it for that contract. It's been, I've heard about mental health medications. When I worked on the insulin issues a few years ago, there would be patients or constituents who said they get established on a certain type of insulin, and then that gets moved off their formulary, and then they have to go back through the process of finding one that works for them. It doesn't make sense, as we've talked about. So I really hope that the bill is successful this year. We do need to get the fiscal note back, so we can't send it to the floor, but we will be laying it over for consideration, and it's one that's, pretty high on my list. So any final thoughts, Senator Mann? So Senate File 1806, as amended, is laid over for possible inclusion. And Senator Mann, Senate File 1877.
Thank you, Madam Chair. 1877 is the point of sale bill. It will require the pharmacy benefit managers to pass down any rebates to the patient at the point of sale. The pharmaceutical chain has become a rather perverted, convoluted chain of events that has significantly raised the prices of medications for patients, leaving us with oftentimes unaffordable options while manufacturers and PBMs take home record high profits. So to break down a very small piece of this chain, when faced with a choice between a high-priced, high-rebate version of a drug versus a low-priced, low-rebate version of the same drug, the health plan will always choose the high-priced, high-rebate version to maximize the rebates that they receive. The result is that in many cases, the patient pays more for the drug than the plan does. And the resulting high cost of that drug at the pharmacy counter means that many patients can't afford to buy the drugs that they need, and they are left without a cheaper option, even though cheaper options exist. So now the way that the health insurance is supposed to work is that the healthy subsidize the care for the sick, but in this case, the sick are subsidizing care of the healthy. The other problem is that if you are a generic or a biosimilar drug company and you want to enter the market at a lower cost, with a lower cost drug, the only way for you to get onto a PBM or a plan formulary is for you to raise your price so that you can offer a larger rebate. So the two bills we're going to talk about next, this one, 1877 and 1876, tackle these issues from two different angles. 1877 requires that all rebates be passed along to the patient in the form of lower prices at the counter. The advantage of this approach is that the PBMs have already done all the program needed to support this approach, and it could be implemented very quickly. Perhaps they will say differently, but it's true. And the disadvantage of this approach is that it doesn't guarantee that the plans will put the lower price drug onto the formulary. So that will be dealt with in 1876, which is the next bill. So this approach has been done both in Maine and Arkansas. There is no reason why we can't do it here as well. If the plans and the PBMs are getting great deals and great rebates, there is no reason why the patient can't get those deals too.
Thank you, Senator Mann. I have two testifiers, Dan Andreessen and Michelle Mack. And Mr. Andreessen, state your name and please proceed with your testimony.
Madam Chair, members of the committee, Dan Andreessen with the Minnesota Council of Health Plans, representing Minnesota's nonprofit insurers. The rebates collected by health plans are used to lower the costs, healthcare costs for everybody in a policy. Just like we spread out the risk, we spread out the benefits to lower the costs for everyone in the fully insured market. If we're required to apply all rebates to individual enrollees at the point of sale, this will result in increase in premiums for everyone else not receiving that point of sale rebate. I want to highlight exemption language that's in subdivision 4, which adds an extra layer of complexity for those in the individual market. So all the products that are in the individual market fall into different tiers called metal levels, anywhere from, and all the levels are defined by a ratio of premium to cost sharing. So you have platinum products on one end, which is 90% premium, 10% cost sharing, down to the other end, which is bronze, which is 60% premium, 40% cost sharing. And this was designed so that when someone's shopping for an insurance product, they can kind of decide what ratio they want. Do they want lower cost sharing, or would they rather have lower premium costs? And so the way that, and because of these differences in the metal tiers and the copay variety in each tier, the way that we're reading subdivision 4 is that it would apply point of sale rebates to some plans but not others. So, and when you're buying that product, you may not know if that's the situation. And so the scenario you could have is someone would buy a gold plan thinking, well, this is what I want because I want low cost sharing. But the bronze would have actually been a better choice for you because the point of sale rebate would have applied to there and you would have paid less in premium. And the mechanism for signing up just isn't sophisticated enough to let you know that. So I think we do have concerns about that. Also want to highlight in this proposal that this will likely affect consumer behavior. Drug manufacturers issue rebates on brand, especially drugs, not on generics, which have higher prices. Consumer would then want to use the brand name drug with the rebates to decrease their copay, which the next bill is going to try to avoid. So we do share Senator Mann's desire to low cost sharing for enrollees, and Senate File 1877 may help a few, but at the detriment of many others. Thank you.
Thank you. Ms. Mack, please state your name for the record and begin.
Hello again, Michelle Mack from the Pharmaceutical Care Management Association, otherwise known as PCMA. PCMA is here today because we have concerns with Senate File 1877 because it will increase healthcare costs by requiring health plans to forfeit the savings achieved through rebates that have been negotiated with drug manufacturers and that help reduce premiums for all members and instead provide point-of-sale rebates to a select group of health plan beneficiaries who are prescribed a limited number of brand name drugs. In year one alone, this legislation would lead to almost $135 million in excess drug spending and over $1.6 billion over the next 10 years. And I've included an attachment in your packets as well for that. Pharmaceutical rebates are price concessions negotiated by PBMs that reduce the net cost of providing prescription drug coverage. PBMs share the negotiated rebates in whole or in large part with the plan sponsors. Employers, and more specifically small employers, may include a contract provision for their PBM to retain a portion of their rebates as compensation for their services. The plan sponsor typically uses the value of rebates to reduce costs to plan members or to enhance their benefits. In the Medicaid market, 99.6% of rebates are passed back, and in the commercial market, 91% of rebates are passed on to the plan sponsors. Employers have the option to apply estimated rebate amounts at the point of sale, but most of them do not. Plan members are very sensitive to premium costs, and point of sale rebates are correlated with higher premiums. Most rebated drugs already have lower cost sharing based on their being preferred drugs under a patient's coverage. The Center for Medicare and Medicaid, CMS, Office of the Actuary found that if Medicare plans were required to apply rebates at the point of sale, manufacturers would offer lower rebates, raising the costs of drugs. CMS estimated that point of sale rebates would cause a 15% decline in rebates. Rebates are the primary way that healthcare payers reduce the net cost of drugs for plan members. While it's not a perfect system, when there is competition available, rebates can save patients a significant amount of money. Point-of-sale rebates, on the other hand, are likely to result in fewer price concessions by manufacturers, tend to increase premiums, and are likely to result in higher costs for most plan sponsors. PCMA believes that Senate File 1877, by shifting rebate amounts to individual enrollees instead of applying them to the entire plan, will likely increase premiums for most enrollees. The bill also does not address the underlying epidemic of high drug prices. And finally, it eliminates plan design choice for purchasers. It is for these reasons that we have concerns with Senate File 1877. Thank you for your time.
Thank you. Members, do you have questions or comments on this bill? No? No? Senator Radke.
Thank you, Madam Chair. And my question comes from the mandate review, which was produced back, well, the copy is dated January of 2023, so it's a couple years old when they did the mandate review on this topic, and it talked about the average increase in premiums of being from 0.5% to 1%, which does seem like a small amount, but when we calculate that out across what it really means to our members, those buying the insurance, it varies across the regions of our state, but it looks like on average it's $6 to $7 per member per month. When we add that up to a yearly premium, we're looking at just short of $300 for a family of four. And again, this is, you know, it's starting in 2023. This is probably more current when we're looking at $300. But the fact is, part of the conversation is about the benefit to those buying the drugs, and they're going to save money. But we turn around and the cost of insurance is being driven up. And it seems like when we work in small bites, a lot of times this is what happens versus if we ever had the chance to look at the overall healthcare program itself. But in this case, we talk about some benefits, but in return, we're actually paying more per month in our health premiums. So that's my question or concern is we move the needle a little bit one way, but it seems to fall back and slap us in the face on the other side. So that's my concern with this is overall we're actually just increasing the cost of our health plans. So thank you, Madam Chair.
Senator Mann, any comments?
Sure, Madam Chair, Senator. So because rebates are so opaque and so secretive, there's no way for us to actually know from a Commerce report what that cost will actually be. So the report is not exactly accurate. What we do know is what happened in Arkansas, where they did implement this language in this bill, and they did a Millman study afterwards, and they showed that premiums did not increase. So this, you know, scare tactic, if you will, that premiums are going to go up has not played out in other states.
Senator Radke, anything else?
Thank you, Madam Chair. Actually, no, I've just, you know, it's starting with data that came from the Department of Commerce. So, you know, we got to base our numbers on something, and that happened to be somewhere where they did some research. But thank you.
Senator Hoffman.
Thank you, Madam Chair. And these kinds of bills excite me because we're finally getting at the transparency piece that you were talking about. I'll never forget when you said to me that company, I won't say their name, but they're on the west part of the metro. We used to call the Seven Golden Sisters, one of those cities out there. I don't know if you're cruising down Highway 100 and whatever, crosstown 62. It'd be this big building, right? Close. And you said 22 billion. And then I remember you looked at me and you said, that's with a B, John, right? And I was like, wow, how can you do that? And you look at companies like PCMA, right, that have assets of $62 million with a revenue of $61 million with only expenses of $26 million. The math ain't working out here when you're saying we're going to give you a little rebate. But what I'd like to break down how much some people are getting on top of those rebates that happen to be working for those organizations. Not that I would say there's anything wrong about that, but I appreciate you bringing these questions to the table. And the thing that gets me is the transparency, the stuff that's happening, you know, in the cloak of dark, right? You know, behind closed doors, so to speak. You're addressing that, and I appreciate you for doing that, and I like this bill. And I said, well, why does Liskey get to be a co-author on these bills and I never get asked? It's like, you know, something I don't. But these are the kinds of bills, and Madam Chair, if you don't mind, these are the kinds of bills that need to be separated and brought to the floor as themselves. And I'm not joking about that either because they have such a significance, a part of who we are as people that are receiving, you know, asset to benefits and such. And so I appreciate you bringing this question to the table and we're having this conversation about it. So with that, I won't even make a motion to move this one to the floor because someone's going to say, well, there might be a cost to it. There might be a cost to it when we know, did I just tell you what PCMA makes, what their assets are and what their revenues were? And there's quite a bit of difference there, Doc, so thanks for pointing this out to us. I appreciate that.
Any other member questions or comments? Seeing none, this bill was heard in Commerce and sent to us, and now we're going to have it, it's going to be referred back to Commerce for their possible consideration. Members, any final thoughts? Senator Mann, any final thoughts?
Yeah, Madam Chair, just one thing. We heard that if we do this, manufacturers will have to increase their cost. And we know that the exact opposite is true because of the rebates. Manufacturers have had to increase their cost year over year in order to provide bigger and bigger rebates. So that is the exact opposite of what we're seeing. That's it.
Thank you, and thank you for bringing this bill forward. Members, Senator Mann's motion is that Senate File 1877 be recommended to pass and be referred to the Committee on Commerce and Consumer Protection. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 1877 is passed and referred to the Committee on Commerce. And Senator Mann, your last bill is Senate File 1876.
Last one, Madam Chair. 1876 requires that the plans include lower cost drugs on their formularies. So instead of the manufacturers increasing their drug costs to get the highest rebates back to the PBMs and the plans, this would infuse competition at the level where the manufacturer interacts with the plans and PBMs to have the lower cost drug so that drug gets on the formulary. They can still get all the other drugs on the formulary. They can still get all the rebates that they want. They just also have to have that cheaper option available. So this gets to that disadvantage of 1877 that wouldn't guarantee that the plans would have that lower cost option on the formulary. So between the two bills, people will either have a low copay, rebate at the point of sale, or a cheaper drug option, all the while allowing the plans and the PBMs to also choose what is best for them, because you cannot tell me that you have to keep all the rebates, offer the highest copays, and you cannot offer a lower priced option. And if that's the case, then we can all safely say that we are not arguing in good faith here. And to sweeten the pot, Madam Chair, I do have an amendment that will allow plans to not have to participate in having a lower cost option on the formulary if they offer a low copay. So in that case, they can keep the most expensive drug option as long as the patient does not have to pay more. And that's the A3, Madam Chair.
Senator Mann moves the A3 amendment. Members, do you have questions or comments about the A3 amendment before we move it? Or seeing no questions, Senator Mann moves the A3 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A3 amendment is adopted. Senator Mann, should we move to your two testifiers? We have Dan Andreessen and Joe Selwood. Welcome back to the table. Mr. Andreessen, please proceed.
Madam Chair, members of the committee, Dan Andreessen with Minnesota Council of Health Plans. So the drug with the lowest list price is not always the lowest cost to the enrollee. So for example, you have two drugs that are completely therapeutically equivalent. The first drug has a list price of $100. The second drug has a list price of $150. But the second drug comes with a rebate of, let's say, $60, which then lowers the cost, net cost to the enrollee to $90. As a health plan, we're going to go with that one drug because it lowers the net cost that we are charging for that drug. Now, under Senate File 1876, health plans would be restricted from using that type of mechanism to lower net costs. I just want to make maybe a couple comments about drug rebates in general. We know this has been a growing topic in Minnesota and throughout the country, and we also share the concerns with the trajectory of the use of drug rebates. We're often faced with the impression that we support drug rebates, but we didn't create this process, but we do want to lower costs. Drug rebates are a marketing scheme used by drug manufacturers to manipulate competition and increase the sale, market share, and revenue of the drugs that they produce. It's a program that may have had good intentions at one point in time, but now being abused to generate enormous profits to push lower cost alternatives out of the way. Now, if rebates are part of this system and we can use those to lower the net cost that enrollees are paying for their insurance, we're going to use them. But if we're limited in using those rebates, then enrollees are going to be paying more. It's a system we must operate in, and we must continue to do so until the rebate system is changed or eliminated. And maybe that's the next phase of this discussion is, I don't know if it's at the legislature or the Prescription Drug Affordability Board, whether we should even keep using rebates in this system. Ultimately, the proposals before you will seek to lower patient costs, but will fall short because the pressure is being put on the drug manufacturers who are setting the price and the rebates of their drugs. We need policies that require drug manufacturers to face real competition and pressure that moves the cost of their drugs downward, and we're happy to partner with Senator Mann or any member of the committee on that. Thank you.
Thank you. Mr. Selwood, please state your name and proceed.
Thank you, Madam Chair and members of the committee. My name is Joe Selwood, and I'm testifying on behalf of the Association for Accessible Medicines. I want to thank Senator Mann for previously addressing AAM's initial concerns with the bill. Additionally, we do suggest striking the first line of both paragraph A and paragraph B of subdivision 4, which requires formulary structure based on the lowest out-of-pocket cost to patients. This deviates from the first 3 sections of the bill, which utilize the wholesale acquisition cost as the metric for formulary placement. By switching to out-of-pocket costs, this approach doesn't account for the fact that patient costs are primarily determined by coverage and plan design. Out-of-pocket costs aren't established until a drug is added to a formulary and assigned to a specific tier. Regarding the language in 2C, 2D, and 3B, which deals with biologic and biosimilar medications, AAM would suggest requiring at least one biosimilar with a WAC price lower than the reference brand product be preferred on the formulary. By requiring a lower cost biosimilar in addition to the reference brand product, we can ensure that biosimilar savings are realized while limiting formulary changes based on WAC price fluctuations. AAM will continue to work with the author as the bill progresses. Thank you for the opportunity to speak, and I'm happy to answer any questions.
Thank you. Members, do you have questions or comments about this bill? No? No, none at all. Wow, quiet group. Senator Mann, any other comments or final thoughts?
No, Madam Chair.
Well, thank you for bringing this bill forward. It's such a complex area, and just to understand the kind of underlining system is really challenging. So trying to find ways that we can help Minnesotans, access drugs more affordably and just access them at all is a real challenge. So I appreciate your digging in and bringing these forward in a way that are, broken up so we can see what we're trying to address and hear, from those stakeholders who are affected. So this bill also needs to go back to Commerce. And so if there aren't any other questions or comments, Senator Adke? No? Okay. I'm sorry. Okay. So this will go back to Commerce. So Senator Mann's motion is that Senate File 1876 as amended is recommended to pass and be referred to the Committee on Commerce. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 1876 as amended is passed to the Committee on Commerce. Thank you. Thank you, Senator Mann. I had Senator Adke first, and then Senator Adke.
Thank you, Madam Chair. Now that we've reached the end of our business for the day, before we adjourned, I just had a question of the rest of the week. We've got full schedules for tomorrow and Thursday, but I've noticed that on Thursday we do have the governor's bills or department bills coming forward, but we don't we're not taking public testimony on those. There's a number of pieces in them that are still controversial. I guess thought process behind that, or can we get that? I think some testimony would be good. If it's repeating what we've had previously in session, that's one thing, but there is some new things to be talked about.
Senator Utke, my thought process on that is that we are taking written testimony on it. We wanted to be able to say we've heard all of the policy bills that the agencies have brought forward and the budget bills, so that they are given a hearing. If proposals move forward in our budget bills later, we will have opportunity for public testimony on the budget bills. And so we will take public comment on that at this time, or at that time. So. And Senator Abler.
Parallel, but not the same. But anyways, I'm just curious, we're getting close to the end here. I'm just, if you're not ready to give us a roadmap today, but I think it would be helpful. Werner, this is a really weird schedule that we have, with the targets ostensibly coming out in a week and a half, and then the bill due in our committee 6 days later. So I understand a little bit of your world, Madam Chair. But so, and I'm not trying to catch you off guard, but I can kind of do the math about what might be happening, but do you maybe just tomorrow want to help people know what schedule you're planning to keep on rolling out your stuff?
Sure. I mean, I can only work based on the information that I have, which at this point, I don't have a target, and I don't have, an indication of exactly when we will receive that. So we work under the, I guess, the process that we've used the past couple of years, that, we have until a week from Friday to get our, policy bills heard, and make sure that we've heard the different appropriation bills that we think we're keeping in mind. And so that's the way we're putting together our schedule. And then, traditionally we have a way to release the budget bill the week of the third deadline, and that's what we're aiming for, but we don't know when we'll receive enough information to create the budget bill. So we don't know exactly if that's still going to be the process. So I'm trying to work under, what we have done in more traditional years, but this year is a very different one. So I'm not sure if that will be what happens. And we want to do the planning because we know that staff in this committee have a lot of work to do as we get closer to putting together budget or policy bills. And we want to make sure that we're allocating enough time for that work to get done. Senator Abler?
Yeah, so I'm not trying to be clever. I'm just trying to, just talk through the process. So I would imagine we'd be doing a markup on April 10th during our regular time would be what I would expect. And then however it rolls out, the Tuesday, Wednesday, and whatever commentary people are going to have. So thank you.
I think that's what we would consider kind of the traditional plan. And so we'll see if things happen, in the meantime, or between now and then, that changes that, I'll be sure to communicate that. So,
thank you.
Yeah. Any other questions? With that, members, we've reached the end of our agenda and we are adjourned.